So Jennifer, thank you so much for participating in the symposium, even if even even it is virtually, and you are sick now. But then thank you so much for finding time and giving us this talk. So recently, you and your colleagues in ASCO, they have released the ASCO guideline for exercise, nutrition, and weight management. So it's very timely to invite you to talk about this guideline. And then we also have a world expert on exercise and in oncology. So we are so honored to host both of you for this talk and then the discussion. So Jennifer, would you start your talk?
Absolutely. Thank you so much for inviting me here today to talk about exercise oncology. Where's the evidence? There we go. Get started. So what I hope to do over the next half hour or so is to review a couple of different kinds of evidence linking exercise to cancer. And we'll start by talking about some of the observational evidence that shows that individuals who are more active are at lower risk of developing cancer and have better outcomes if they do develop a malignancy. Then we'll talk in some detail about the recent American Society of Clinical Oncology guideline on exercise, diet, and weight management during cancer treatment, and really review the evidence that made up that guidance. And then we'll finish by talking about some of the evidence gaps and a number of ongoing randomized trials that will try to address those gaps. But we'll start really from the place where this field really began. Why do we think about a connection between exercise or physical activity and cancer? And that really started with observational data that demonstrated that people who are more active are at lower risk of developing malignancies. There are many different studies that have demonstrated this to be the case. This was a large analysis that was published now a few years ago that included data from 12 cohorts prospectively collected in the United States and Europe that included more than 1.4 million individuals. During 11 years of median follow-up, more than 180,000 malignancies were diagnosed in these individuals. In all of these studies, physical activity was assessed, and generally through self-report. And what these analyses demonstrated was that physical activity was associated with a lower risk of 13 individual malignancies. Now, certainly physical activity is linked to other lifestyle factors, and in particular obesity. But even after adjusting for body weight, the relationship between physical activity and lower cancer risk was still significant in 10 of these 13 malignancies. We also know that physical activity and fitness are associated with outcomes in individuals who are diagnosed with early stage, potentially curable cancers. On the left-hand side of this slide, you see an analysis that looked at the relationship between cardiorespiratory fitness and cancer-related mortality in individuals diagnosed with cancer at the Brigham and Women's Hospital who had undergone VO2 max testing. And what the investigators demonstrated was that individuals who had higher cardiorespiratory fitness had a lower risk of cancer-related mortality compared to individuals with lower cardiorespiratory fitness, even when balanced for stage, for type of cancer, and other treatment-related variables. There are also a number of different studies that look at post-cancer diagnosis physical activity patterns. These studies have demonstrated that individuals who are more physically active after cancer diagnosis have a lower risk of cancer-related mortality compared to individuals who are less active. This was a meta-analysis published by Christine Friedenreich now a few years ago, looking at prospective cohorts in breast, colorectal, and prostate cancers that demonstrated that looking at active versus inactive cancer survivors, the individuals who engaged in regular physical activity after cancer diagnosis had an almost 40% lower risk of cancer-related mortality compared to individuals who were inactive. So these data have led to recommendations for exercise as a part of cancer prevention and control. And a number of groups have put together recommendations for cancer survivors in particular. On the left-hand side of this slide, you see the National Comprehensive Cancer Network, who developed a survivorship guideline recommending exercise for cancer survivors. The American Cancer Society has also, over the last decade, put together guidelines on diet and physical activity for cancer survivors, again, recommending regular exercise as a part of survivorship. But one of the gaps in these guidelines was, what should people do in terms of exercise, diet, and weight management during active treatment? Many of these guidelines really focus on the post-treatment cancer survivor, and there's less information about the value of interventions during cancer treatment. And that was really the genesis for developing this guideline from the American Society of Clinical Oncology, which was released in May of this year. The goal here was to really look at the benefits of making a lifestyle change during cancer treatment. And we're going to break down this guideline question a little bit to really study what we were trying to accomplish with this guidance. First of all, this guideline really focuses on adult patients and not pediatric patients, given the fact that there just isn't as much evidence in kids. The guideline really also focuses on individuals undergoing active treatment with systemic antineoplastic therapy, or chemotherapy as we more commonly call it, or radiation, or individuals who are in the perioperative period. So this does not include recommendations for individuals with breast cancer who are being treated with anti-estrogen therapies. The rationale here really is that those individuals are very well represented in those prior guidelines that we looked at from the American Cancer Society and other groups like the American College of Sports Medicine. So this guideline was really focused on individuals undergoing more intensive therapies in the neoadjuvant or adjuvant period. The guideline also looked at evidence that came from interventional studies, so randomized controlled trials involving exercise, diet, or weight control. And so this doesn't deal with observational evidence, really just data from randomized trials. And it also doesn't include things like mind-body exercise, like yoga or Tai Chi, things like dietary supplements. And it also doesn't include things like malnutrition or cachexia. It really looks for an oncologist or other individual that's working with cancer patients on what you can tell your patient as they start their therapy they can do to potentially improve their outcomes during their treatment. The last piece of this is that it really focuses on outcomes related to treatment toxicity, quality of life, and cancer control. So it doesn't focus on can people change their lifestyle, but really what are the concrete benefits of doing so. So here you can see our methodology. So the evidence that we considered for the creation of this guidance really focused on a systematic review of the literature, looking in particular for systematic reviews, meta-analyses, and randomized controlled trials that involved at least 25 subjects per arm. Again, adults during active treatment, evaluating aerobic and resistance exercise, specific diets and foods, as well as intentional weight loss and avoidance of weight gain. We were interested in outcomes like quality of life, physical function, treatment toxicity, and in particular on cancer control, recurrence, survival, second cancers, et cetera. We assessed the quality of the studies that we included using grade methodology. And so the individual data points were graded to be high, moderate, low, or very low quality of evidence. And this was assigned by our project methodologist. Here's our quorum diagram. So you can see we started with a large volume of data, so 3,544 potentially relevant abstracts with an additional 25 papers that were identified through review or reference lists. We ultimately identified 275 papers for full text review and found 78 papers that met the selection criteria. This was 52 systematic reviews and 23 randomized trials. One of the things that I do think it's important to recognize here was the way that this evidence was really distributed. We found 42 systematic reviews for evidence and only 9 for diet and 1 for weight management. The most commonly studied types of cancer were breast, prostate, lung, and colorectal cancer. Now, this evidence base really matches the NCI-funded grants in the period of time between 2004 and 2014. So a lot of these studies made up the bulk of the evidence that we evaluated. And you can see here in the red line were studies that were funded that focused on physical activity versus diet and weight control. So over time, there have been a larger number of physical activity studies that have been funded. The other thing that I think is important in the funded projects historically is that a lot of the outcomes of these studies really did focus on, can you increase physical activity during treatment? Can you help people lose weight or change their diet? And a smaller number of projects focused on concrete changes and benefits of these types of changes, things like physical functioning, symptom management. So what we really found through our literature review reflected the projects that had been funded in the preceding period, not surprisingly. So what did we recommend? So our first question that we tried to address was, does exercise during cancer treatment safely improve outcomes related to quality of life, treatment toxicity, or cancer control? And as a panel, we recommended that oncology providers should recommend aerobic and resistance exercise during active treatment with curative intent. And the rationale behind this recommendation was that exercise interventions during active treatment reduce fatigue, preserve cardiorespiratory fitness, physical functioning, and strength. And in some populations, most specifically in women with breast cancer, they improve quality of life and reduce anxiety and depression. So since today's talk is focused on what's the evidence, I wanted to drill down a little bit more into the evidence that really made these recommendations possible. So the evidence quality was moderate to low, but the strength of the recommendation, so looking at the balance of the potential benefits versus the risk, the strength of the recommendation was strong. For those of you who seek out this publication in the Journal of Clinical Oncology, there are a number of tables that accompany this in a supplement that really demonstrate the large volume of evidence that shaped this guidance. And you can see here, this is a table looking at each of the outcomes that we mentioned, VO2 max, fatigue, self-reported physical functioning. This table, I could only fit 6 of the 10 outcomes, but just wanted to demonstrate the large number of subjects and studies that were included in this consideration. So for example, VO2 max included data from more than 1,300 participants in 13 studies. You see an SMD of 0.46 higher for people who participated in exercise interventions. The certainty of the evidence was moderate. Again, we recognize that there is some inconsistency. The studies have a lot of different designs. Fatigue, also a large body of data, 1,788 participants, 21 studies, an SMD of 0.67. Again, moderate quality evidence because of some of the inconsistencies. And we won't go through each of these different topics, but I just wanted to demonstrate the large number of studies that really made up this guidance. And you can see here another table that went, those of you who are interested in this, we really included a lot of different tables that include the full depth and breadth of this evidence, along with the quality ratings. You can see this was only 2 of 9 meta-analyses supporting exercise's role in helping to preserve cardiorespiratory fitness. So moving forward with our exercise recommendation, the other piece of this was that oncology providers may recommend preoperative exercise for patients undergoing surgery for lung cancer to reduce hospital length of stay and postoperative complications. The evidence quality here was low, and the strength of the recommendation was weak, and this is why this is phrased may recommend. looking at the difference between the quality of evidence here as opposed to our recommendation for exercise during chemotherapy and radiation. This is the whole table and not a piece of it. And you can see far fewer studies, but the data specifically in lung cancer, looking at both postoperative complications and hospital length of stay, although the evidence quality was low or very low, the evidence that was available suggested benefit, whereas looking at individuals undergoing other types of surgery, abdominal surgery in particular, the evidence was less strong, and the findings in those situations were quite inconsistent, leading to us not be able to make a more blanket statement about the potential value of exercise in the perioperative setting. The other question that we really wanted to address as part of this guideline is exercise safe during treatment. Oncologists often worry that during intensive treatments, exercise potentially could be harmful to their patients. We did recognize that the frequency of reporting adverse events was somewhat variable across studies, but the rate of exercise-related adverse events was low. The literature did identify 11 systematic reviews and meta-analyses that reported exercise intervention adverse events during cancer treatment. The most comprehensive of these systematic reviews was one by Scott et al., published about 4 years ago, and they looked at both aerobic and resistance training studies and included 14 different trials. 13 of these did include a mention of adverse events, and across these, only 11 exercise-related adverse events were reported, including single digits of things like hypotension, syncope, and acute MI. Most of the events, and there were only 4 of these, were musculoskeletal injuries. And this systematic review did have quite a high quality rating. So as a group, we felt comfortable recommending that overall exercise was safe during chemotherapy, radiation, and in the perioperative setting for lung cancer. Now, I know that today's talk really focuses on exercise, but I would be remiss not to mention the other topics that we covered. We were very interested in looking at whether a particular dietary pattern or food during cancer treatment safely improved outcomes related to quality of life, treatment toxicity, or cancer control. And in this instance, unfortunately, there was insufficient evidence to recommend for or against dietary interventions during treatment, with the exception that we did note that neutropenic, specifically diets omitting raw fruits and vegetables for the purpose of decreasing infection, were not recommended during active treatment. The evidence really suggested that this type of diet did not lower the risk of infection and had the potential risk of depriving individuals of fruits and vegetables and the nutrients that go along with those. Here you can see a difference looking at, again, what is the certainty of evidence. This is the entire table again, looking at dietary restriction and its specific foods. You see there were a total of 13 studies that were included. They had extremely variable study designs. They were looking at different diets. This really made it impossible for us to develop any concrete guidance around diet. Similarly, weight management, there was insufficient evidence to recommend for or against weight loss or the prevention of weight gain interventions during treatment based on the literature that was available. And here you can see the one table that we were able to develop regarding weight management that included only 4 randomized trials. So in this process, we identified a number of evidence gaps. Clearly, diet and weight management in general, there's a huge gap in the evidence, even about the effect of these types of interventions on things like quality of life. But we did also find that although there was a lot of evidence about exercise during cancer treatment, there was much less about exercise or any other interventions during the treatment of advanced disease. And there was also not sufficient evidence to draw any conclusions about the impact of exercise or other lifestyle interventions during treatment on either treatment outcomes or on cancer outcomes like recurrence, progression, or survival. So I want to now turn to how do we fill in these gaps? These are obviously very important gaps. We've recommended exercise generally for symptom management during cancer treatment, but how do we get to the point where we know whether these types of interventions actually help increase the likelihood that a person would survive their cancer. And unfortunately, there are a number of studies that are looking at the impact of exercise with or without dietary change on cancer outcomes that are currently ongoing and will provide some evidence about the benefits of these types of interventions in the coming years. I wanted to spend a minute or two talking about a study that we're currently leading in the United States and Canada called the Be Well or Breast Cancer Weight Loss Trial. This is a study that was designed to look at whether a lifestyle-based weight loss program, so involving both exercise and dietary change, on cancer recurrence in women with a BMI of at least 27 who were diagnosed with early-stage breast cancer. So the study was designed to enroll 3,136 women. They all had to have stage 2 or 3 breast cancer. They had to have a BMI of at least 27. And they were randomized to a 2-year health education and telephone-based weight loss program, or to a health education alone arm. The primary outcome was invasive disease-free survival, which is an aggregate endpoint that includes cancer recurrence, both distantly and locally, the formation of a new breast or other cancer, or death from any cause. This is a study that is supported by the National Cancer Institute in the United States. The intervention that we used was a standardized 2-year telephone-based weight loss program where each patient was paired with a weight loss coach based at Dana-Farber. And our intervention goals really focused on both nutrition and physical activity. We were hoping to achieve a 10% weight loss for study participants, achieved through a 500 to 1,000 kilocalorie a day deficit, with an increasing physical activity goal over the course of the study. During the first 6 months, where we really focused on the most intensive period of weight loss, patients were instructed to try to attain 150 minutes of aerobic activity. And then during the weight maintenance phase, we increased that to 220 minutes of exercise each week. The individualization of our intervention included the provision of a lot of different tools, including a wireless scale, a cookbook, meal replacement shakes, activity trackers, and we used a toolbox strategy to really enhance individual weight loss. This study was enrolling patients between 2016 and 2021. You can see on the right-hand side of the slide our enrollment curve. You notice that we really met our enrollment goal every month until March of 2020, when things sort of fell off the rails a little bit, but we ultimately were able to complete our entire enrollment by about 6 months after we had initially planned. So we completed this in February of 2021. We ultimately enrolled slightly more patients than we had attempted, so 3,181 women. Notably, the study did pass an interim analysis in 2019, demonstrating significant weight loss between the 2 arms. That was a condition to meet its full accrual, and so we continued to enroll patients. We ultimately enrolled patients from more than 600 sites across the US and Canada. 25% of our patients are racial and ethnic minorities, and about half of our patients were enrolled from community-based sites and the other half from academic sites. We've had very good retention to interventions at 3.5 years median follow-up, and we hope to have our primary results sometime in 2024, demonstrating whether this diet and exercise program can reduce the risk of cancer recurrence in women with early breast cancer. There are a number of other studies that are ongoing looking at breast cancer patients that involve diet and exercise. The Dana-Farber trial is an Italian study that looks at Mediterranean diet as well as exercise, and that enrolled 1,542 patients. And the Success-C trial was a study that's reported preliminary outcomes looking at weight change in women with breast cancer in Germany. I am sure you're going to hear a lot more during this conference about the Challenge trial led by Dr. Cornea. This study really focuses on exercise in patients with colon cancer, enrolling 962 individuals with, again, higher stage colon cancer. There's also another study focusing on individuals with prostate cancer, and this is the only study to really focus on individuals with later stage disease, looking at a 2-year exercise intervention in men with castrate-resistant prostate cancer. The final study is the LIVES trial, which is a study that looked at exercise and dietary change in women with ovarian cancer. This study enrolled 1,205 women with ovarian cancer and is expected to announce results in the next 1 to 2 years. So over the next few years, we'll have a lot more information about the impact of exercise and dietary change on cancer outcomes in individuals with a variety of different diseases. The one last gap I wanted to talk about before we turn things over to questions was what about the effect of exercise on treatment completion or treatment intensity? In the ASCO guideline, we found that exercise reduced a lot of the side effects that people experience as a result of cancer treatment, things like fatigue, loss of physical functioning, anxiety, and depression. So it would follow that exercise would potentially help people more successfully complete their cancer treatment. Dr. Cornea, in fact, has led a few studies which demonstrated as secondary outcomes that patients who did take part in exercise interventions were more likely to complete their cancer treatment. And a number of studies have explored this, but unfortunately, to date, in most of these studies, this was not the primary outcome, and the results have been a little heterogeneous. And this prevented us from being able to make a recommendation about the impact of exercise during treatment on outcomes more broadly during our ASCO evidence review. In response to this, the National Cancer Institute in the United States recently developed a consortium called Exercise Nutrition Interventions to Improve Cancer Treatment-Related Outcomes, or ANICTO. This consortium is designed to evaluate through a number of individual studies whether exercise and dietary interventions during treatment can reduce chemotherapy toxicity and increase received dose intensity, which looks at both the dose of chemotherapy that's delivered and the time over which it's delivered. If a patient receives a total dose of chemotherapy over 3 months, that tends to be much more effective than if it takes 6 months to deliver that treatment. So this consortium has funded 4 individual projects and a coordinating center. The projects focus on breast cancer, ovarian cancer, colon cancer, and rectal cancer. And although this is probably too small to see, you can, on the right-hand side, you see where in the United States these different studies are based. We are leading a study along with Katie Schmitz, now at the University of Pittsburgh, and Nate Berger at Case Western University, that is looking at exercise coupled with protein support to preserve functional status and preserve disability in women with breast cancer undergoing chemotherapy. This study, called the Thrive 65 study, will enroll 270 women aged 65 or older who are being treated with an anthracycline or taxane-based chemotherapy for stage 1 to 3 breast cancer. They're randomized to an intervention that involves resistance and aerobic exercise training coupled with protein support, compared to a supportive care program that really focuses on mindfulness, art therapy, stretching, and healthy nutrition. Here on this very busy slide, you can see a little bit more of the detail about our intervention. We are using a virtually supervised progressive resistance exercise program coupled with home-based walking. The participants will all work with a coach over a virtual platform twice a week during their chemotherapy, and will also receive a telehealth visit with a nutritional counselor, and will continue to complete nutrition records during their treatment and their training to ensure adequate protein support. So this project, as well as the other 3 projects supported by this consortium, will start enrolling patients in the new year. Again, hoping to provide more evidence about the benefits of exercise in terms of preserving treatment intensity. So where's the evidence? We covered a lot of different kinds over the last few minutes. Again, I hope to leave you with the sense of the really consistent observational evidence showing us that individuals who are physically active are at lower risk of developing cancer and tend to do better in terms of cancer-related mortality if they are diagnosed with an early stage malignancy. There's consistent evidence from randomized trials showing that exercise during cancer treatment has significant benefits in lowering toxicity from cancer treatment, like fatigue and loss of physical functioning. But there remain important evidence gaps about whether interventions during and after treatment improve cancer-related outcomes. And we really look to these studies over the next years to fill in some of these gaps and help make our guidance for our patients more specific in helping them to hopefully use these types of interventions to improve their outcomes. So thank you very much for your attention. I'm happy to take questions.